Hello, everyone. My name is Dr. Hassan Hussain. I'm an assistant professor at Dalhousie University in ophthalmic plastic and reconstructive surgery. Thank you for joining us. Today, I will be talking to you about Merkel cell carcinoma. So Merkel cell carcinoma is a fairly rare entity, but it's a life-threatening entity that has very significant consequences for the patient. It can be difficult to diagnose initially, so it is important to have this in the back of your mind when seeing patients with eyelid malignancy, or even with a lesion which is somewhat displaying some suspicious features. So this lady, young lady, was referred to me. She had been seen for a few months and treated for a possible chalazion, but this lesion appeared to be getting bigger and had some changes which were disturbing. And indeed, she ended up having a biopsy which confirmed the presence of a neuroendocrine tumor, which was Merkel cell. So looking at it, you could see that it does display some possible chalazion type features. However, note that it's originating from almost the lid margin and also the tarsal plate. It has displaced the eyelashes and caused some matarosis. It has a violaceous, sort of a stuck-on grape appearance, as is commonly described. And so if you have any suspicion that this looks unlike a regular chalazion, the patient should be having a biopsy performed. And so this lady underwent a large upper resection, and then they cut her beard flap, and then needed extensive radiation and further treatment for this lesion. So we'll talk about establishing the diagnosis first of all, and just to give you some historical perspective, the Merkel cell carcinoma bears the name of the cell discovered by Friedrich Merkel in 1875, and it was first described in 1983 by Lamping in ophthalmology. And Merkel cell is a non-dendritic, non-keratinocytic, clear epithelial cell. This cell is located in or near the basal layer of the epidermis, and it is associated with nerve termination. So this cell is believed to be a mechanoreceptor that mediates the sense of touch. And there is increasing evidence that the Merkel cell polyoma virus has a role in the development of this carcinoma. Indeed, in a study by Borchert in the Journal of Virology, they found that this virus is integrated in about 90% of Merkel cell carcinomas and appears to interfere with tumor suppressor pathways. So what is the epidemiology of this lesion? Well, in the literature, there have been about 1,200 cases of Merkel cell carcinoma reported. The incidence is estimated to be about 0.45 per 100,000 population. 50% occur in the head and neck region, 40% in the extremities, and 10% in the buttock and trunk region. 5 to 10% of Merkel cell carcinomas occur in the eyelid. There is no gender predilection with MCC. So the history usually is of a fairly rapidly expanding mass over a few weeks or month or so. The symptoms are usually less than 6 months. And it is often, as mentioned, confused with benign inflammation, such as a chalazion. And the clinical features are one of a purple or red swelling of the skin with a mass effect. And there's a mnemonic which has been described in a paper in the Journal of American Academic Dermatology in 2008 by Heath. It is the AEIOU mnemonic, as in the vowels. So that is asymptomatic, expanding rapidly, immune suppression, older than 50, and ultraviolet exposed site on a person with fair skin. Of course, not all of those are, need to be covered. So my lady was under 50, but certainly the other parts of the mnemonic applied to her. So what does the histopathology show? Well, it is a small cell carcinoma composed of granular cells, scant cytoplasm, prominent nucleoli, oval cell nuclei. Immunohistocytochemistry demonstrates cytokeratin 20 and neuroendocrine markers. So if you're suspecting a neuroendocrine tumor, you should be asking for those markers. It is negative for S100 and human melanoma markers, which differentiate it from the amelanotic melanoma. And the presence of more than 50% of Ki67 plus is a negative prognostic indicator. This is a marker for replication. We also know that high expression of BCL2 and MIB1 are a bad prognosis factor. And finally, staging. There have been studies looking at staging according to the American Joint Committee of Cancer edition. This showed that if patients had lesions which were over 5 centimeters, this resulted in significantly bad prognosis with risk of metastatic death. And we know that lymph node metastasis at presentation is the strongest predictor of reduced disease-free survival and further, of course, metastasis. So what are the risk factors for a Merkel cell carcinoma? Although it is suspected to be related to sun exposure, paradoxically, it for some reason affects the upper eyelid more than the lower eyelid. And we know, compared to basal cell carcinoma, which is a actinic tumor occurring in the lower lid because of the higher exposure of the lower lid to the sun, but for some reason, Merkel cell appears to occur more in the upper eyelid. There might be more mechanoreceptors in the upper lid. We know that age greater than 50 years is a risk factor. And according to the mnemonic I mentioned, immune suppression is a risk factor, such as organ transplant, AIDS, or chronic lymphocytic leukemia. So differential diagnoses, well, of course, like I mentioned, chalazion, think about basal cell carcinoma, a vascular lesion, Kaposi sarcoma, malignant lymphoma of the skin, and metastasis. So let's come to patient management. The natural history of this lesion is that there's a local regional recurrence of between 30 and 60%, with up to 1/3 of patients developing distant metastasis. The estimated mortality for Merkel cell is about 25 to 35% of patients. The concern is, of course, the regional spread to lymph nodes. The most common sites of systemic metastasis are the bone, brain, liver, and lung. And there have been some papers of complete spontaneous remission of non-palpable Merkel cell carcinomas. But this is, of course, a very rare occurrence. And the process of that is very swift and dramatic. And it includes regression of the metastasis, but this is a very rare occurrence and probably denotes that the immune system has become aware of it and therefore resulted in destruction of the tumor, whereas there was previous immune suppression. Can this be treated medically? Well, chemotherapy is used for Merkel cell, usually as an adjuvant to other forms, particularly for systemic dissemination. Drugs such as cisplatin, cyclophosphamide, doxorubicin, vincristine, and 5-FU. Merkel cell tumors often express the PD-1 ligand, and therefore targeting the PD-1 ligand, such as with monoclonal antibodies, these new drugs, the immunotherapy drugs, and there is one which is FDA approved called avelumab, which is now approved by the FDA as a targeted therapy for Merkel cell carcinoma. Radiation has also been used. For non-ocular Merkel cell carcinoma, adjuvant radiotherapy at a dose of 50 gray is reported to decrease the rate of recurrence. For the eyelid, the institution of this radiotherapy is the use of radiotherapy is institution dependent. There was a study at the UCLA in 2018, and they found that adjuvant radiotherapy did not improve overall survival if the tumor cells have the capacity to spread beyond the primary site. So if they displayed evidence of, if the patient had evidence of already disseminated disease or markers within the cancer which showed aggression. Um, really, the main approach to this tumor primarily is surgery. And as for my patient, she needed aggressive surgical resection with wide local excision and frozen section evaluation. You need at least 5 mm margins. You need to perform sentinel node biopsy. And my lady required that, as well as neck dissection. There is a greater likelihood of positive results with SLN, which is sentinel lymph node biopsy, depending on increased tumor size, high tumor thickness, high mitotic rate, and infiltrative growth pattern. Prognosis, well, like we mentioned earlier, the main factors that influence prognosis are size. So over 2 centimeters has a poor prognosis, and there's a higher mortality in men. Of course, metastatic disease denotes likely significant aggression and poor prognosis with potential fatal disease. And some of the complications that we know from this management, particularly with immunotherapy, we're now seeing that certain drugs such as avelumab can result in other side effects systemically, which sometimes can affect the patient's neurology, and they may require treatment for that at the same time. So this is a very aggressive tumor in summary. It requires the clinician to be alert for its presence, early biopsy and diagnosis, and either management or referral for management as early as possible denotes the best chance for the patient and their survival. That's the end of that case.